Hello, everyone. I am Aubrey Rhodes, and I have the privilege of serving as LCRF's Executive Director. Our mission here at LCRF is to fund research for the prevention, diagnosis, treatment, and ultimately the cure of lung cancer. And like it says in our name, research is our primary focus. And we believe that the informed patient is empowered to make the most of research. And so that's what our programs are here. They're designed to bring the latest in research to all of you. Today, we are going to be covering several important topics that came out of ASCO's annual meeting, which took place earlier this month. Every year, ASCO brings together really the entire cancer community, oncologists, researchers, patients, advocates, other industry leaders from around the world to share the latest advances in cancer research and in treatment. It's one of the most important scientific meetings of the year and often provides an early look at discoveries that might just shape the future of cancer care. And for organizations like LCRF, meetings like ASCO are really especially meaningful because they represent the culmination of years of scientific discovery and research investments. And we get to see the impact of that research move from the lab to the clinical trials and ultimately into the lives of patients. So I'm looking forward to hearing about the updates today. I know there were several important lung cancer updates in ALK positive research, in RET and squamous cell. So we're excited that we'll be discussing those. Our team was actually on the ground in Chicago at the meeting, and we were meeting and talking with several experts in the community, kind of just hearing their insights. Morgan Fitzgerald on our team did some really great interviews with prominent leaders in the field. And if you haven't had a chance to see those, I would really encourage you to check them out. They're all available on our Instagram, and they really break down the science in an easy to digest way. So quick reminder before we get started, everybody please stay on mute. The chat is open, but we ask that you refrain from asking any personal questions in the chat. We do have the captions enabled. You can turn those off if you would like in the settings. And without further ado, it is my pleasure to introduce to you today our moderator for the call and chair of our Education and Engagement Committee, Dr. Isabel Preeshagul. Dr. Preeshagul is an assistant attending on the thoracic oncology service at Memorial Sloan Kettering.
Thank you so much, Aubrey, and the LCRF team for having me back again today. ASCO was a whirlwind, and we have a lot to cover. So I really want to keep it high level and keep us going through the topics. We're going to try to get through as much as we can, but understandably so, we can't touch upon can't touch upon everything. So if there's some burning question you have, please feel free to put it in the chat. And if it's natural at that time, we will answer it. Otherwise, we will go through it at the end of our meeting today. I am thrilled to be joined by two exciting guests that I have today. I have Dr. Sarah Goldberg and also Dr. Logan Roof, excuse me. If you could please take some time to introduce yourselves a little bit, and then we'll dive right into the information.
Go first. Hi, everyone. I'm Sarah Goldberg. I'm a thoracic oncologist at Yale. I'm also the division chief of thoracic oncology here and run our Center for Thoracic Cancer. So it is so wonderful to be here with all of you. I'm so excited about how many people are on this call. It's fantastic, and it's always wonderful to work with LCRF. So thank you all for having me. Really excited for the conversation.
Hello, everyone. My name is Logan Roof. I am a thoracic medical oncologist at The Ohio State University. And also, this is my first LCRF talk for ASCO, so I'm very excited to learn myself, but also to help provide any insights that I can, and also very excited that there's such a large showing today. So very excited for the talk and the engagement. So thanks again.
Great to have you both here. So we're going to start at the top, and what that usually means is we're going to focus on anything that was presented at the plenary session, which is like the big session that happens smack in the middle of the conference, where any practice-changing, late-breaking, really exciting data gets presented. And anytime there's anything in the lung cancer space, we all go, yay! And there were actually two abstracts. So we're going to talk about both of them and how if we think they're practice changing or not. And also, if you're not on mute, if you could just please make sure to put yourself on mute if you're one of the listeners. So let's start with libretto. So libretto 432 was a study in the adjuvant setting. So adjuvant means patients that have cancer that was resected up front, and then they went on to get some kind of chemotherapy, and then they went on to either receive targeted therapy or a placebo. So this was basically focusing on patients that harbor RET fusions, which are rare. It's seen in maybe like 1 to 2% of patients, but can be practice changing, and the results were astounding. So I'd like to hear just from both of you what your key takeaways were from Libretto 432, if this is something that excited you or not really relevant to your practice. Sarah, I see you smiling if you want to go first.
Yeah. Yeah, so I mean, so plenary sessions, like thousands of people in the room. It's always very exciting. Um, and it was chosen for that session because it's such an important study. So just as you described, this trial was for patients who had surgery for an early stage lung cancer, and then most of them actually got chemotherapy, which is standard for a lot of people with early stage lung cancer after surgery. And then they either got this RET inhibitor or not. And it was a very positive study, meaning the RET inhibitor really helped to control or to reduce the risk of the disease coming back. And so that's absolutely practice changing. I think that's something that if we weren't already doing that in clinic, which we could talk about, I think everyone is now going to start, because that's our goal after surgery. Is we don't want the cancer to come back, of course. And so if there's anything that we can do to reduce the risk, we want to do that. Really, our number one goal is to make sure that that translates into people living longer. But we've seen with now a few studies that when you can have this really long time of preventing the cancer from coming back, it often means people will live longer because of it, which is not so surprising. So I think it's an amazing study. I think that this is what we should be doing for patients. The reason it's, maybe I smiled when you asked that question, is it's not that common of a scenario, right? Like RET is pretty rare, like you said, and then they have to have early stage cancer that had surgery. So it's not like we see these every day, but absolutely, if we see it, it changes what we do.
I totally agree with Dr. Goldberg and want to echo that. So to that point too, RET is very rare, but this is a very important study. They mentioned in the study that they had to screen thousands of patients to find about 150 patients just because of the rarity of this mutation and the setting where you're getting surgery and then chemotherapy and then qualifying for this RET inhibitor. So absolutely, when we see this, when we find this, this is practice changing. All the more reason to advocate for next generation sequencing molecular testing with any type of lung cancer diagnosis, early stage, all stage. And for me, absolutely practice changing. We've seen this in EGFR, ALK, other driver mutations, and so certainly RET is now coming onto the scene, which is very exciting. Questions that I still have regarding the role of chemotherapy. Certainly, most of these patients got chemotherapy, and so that was standard. But then going to be duration of how long do we keep them on that oral drug? What side effects are popping up? Is, we want people to live longer. We also want them to live well during that time. So what is that looking like in reality? And what's that duration of time that we keep them on that medicine?
Yeah, I think you bring up such a good point there. These are patients that essentially were cured with surgery, right? And then everything we're talking about after that is more of like an insurance policy. So I was fortunate enough to have some folks on this study, and selpercatinib is not a cakewalk, right? There's its toxicity, and then these patients are taking it. They're not seeing the gratifying results of like, oh, my tumors are shrinking in the stage 4 setting. Oh, it's worth it. The juice is worth the squeeze. It's almost like, well, I'm having good scan after good scan after good scan, but like, do I have to take this forever? And I had a couple patients come off because of toxicity, and I had some patients that were able to continue. But I think, it's not super easy. And I don't think we know the ideal amount of time after they complete their 4 cycles of adjuvant treatment, how long they really need to be on Selper for. So I think that's a really good point. But for me, this is practice changing. If I identify someone with a RET fusion, I am going to offer this, just like I do for Adora and just like I do for EGFR patients and Alina for patients that harbor ALK fusions. Same for you both?
Yes.
Okay.
Yes.
Anything else take home from this topic before we move on to our next exciting topic in the plenary? Doesn't seem like it. Okay. So next we're going to talk a little bit about Harmony 6. So Harmony 6 was a study for patients with stage 4 lung cancer that that were either randomized to receive this drug called ivonescimab. So ivonescimab is a newer kid on the block. It's a bispecific antibody that has an immunotherapy head and then a VEGF head. So the VEGF head sort of stops blood vessel growth and prevents metastasis, and the immunotherapy head functions like a PD-L1 inhibitor. So, this drug is trying to find its home, is what I'm seeing. And while it was exciting to see some of these results, it does look like there's a signal to combine ivonescimab with standard of care chemo. It was a very, unique patient population, patients that were only in China. And it also looks like ivonescimab is being explored for patients that have EGFR alterations, and Harmony 6 was patients that don't have driver alterations. So for me personally, my takeaway was I definitely think there's a place for ivonescimab, but I'm just not sure where it lives. And I am struggling with that when I was interpreting the data. But I would love to hear from both of you, and maybe Logan, we start with you. Oh, Sarah, you came off mute. But
Go ahead, Logan, you go first.
just key takeaways and like what was your take home about this study?
I agree. I think this study is an important study. I think anything that we can have more treatment options for patients, also in difficult to treat scenarios, that can be definitely helpful as well. The big question for me, I think the big question for a lot of folks is this going to be relevant for our patient population? This was done primarily in another country. We don't yet know with our patients and our healthcare system with our PD-1 inhibitors and chemo combinations and things, is this going to be relevant for them? So that's a question that I have yet. So I think it's important. I'm not yet sure exactly where it fits into my treatment paradigm, but agree that it warrants further study and it is exciting.
Yeah, I'll just add it's not yet approved here. I think it is approved in China actually. So, they have to deal with having to figure out when and where and how to use it. But for us, it's not approved, but it is in a whole lot of clinical trials. So there is this very strong signal that it may be better than the immune therapies we have now, but to me, we don't really know that yet. Just as you both have said, this was entirely done in China. It was just in squamous cell carcinoma, so that doesn't apply to people with any other type of lung cancer, like adenocarcinoma, which is more common, or mutation subsets like EGFR and others. So I think it's exciting. Potentially, we have a better immune therapy, but there's many trials that are ongoing. So I think we will have this answer. We just don't really have it yet for our patients, but it doesn't matter so much because we don't have it approved anyway, so we can't even use it. But we do, once we started to see these really exciting trial results, not this one, but in the past, we opened trials with this drug at Yale because we wanted to have the ability to provide it for our patients when they're eligible for the different trials. So I think it's an exciting drug. I think everyone's watching it to see what's going to happen with the other trials and how it will move forward, but not quite there yet to me.
Yes, and I thank you for clarifying that. This is only being used in clinical trial setting in the United States, and we do have clinical trials with ivonescimab for patients with stage 4 lung cancer that don't have driver alterations, and then also for stage 4 lung cancer patients with driver alterations. Like we have a study with datopotamab deruxtecan right now. So anyways, yes, I think it's another, to me right now, it's another me too. It's another option, potential option for patients in the stage 4 setting, but I'm not sure where it lives, but still exciting to have more options. Next, unless there's anything else we want to talk about, I will briefly touch upon daraxonrasib. This is outside of our scope. This was presented in the pancreatic space. This is a RAS-on inhibitor for patients that have KRAS-driven disease. It was presented in the pancreatic space for patients with stage 4 pancreatic cancer and received, not only a standing ovation in the room, which was a really powerful moment to see, but like tears streaming down, people's faces, patients there, family members there, caregivers, advocates, doctors, researchers, nurses, you name it. Like it was like so moving. I almost was like, why am I in thoracic? This sounds so cool. This is great. But we had our standing ovation 2 ASCOs ago. So, but anyways, it's really exciting. Would love to hear just both of your thoughts about daraxonrasib and is there a role or will there be a role for this for patients that harbor KRAS alterations in the thoracic space?
I'll take that. I'll take it first this time. So I agree. It was so exciting. I mentioned before there's thousands of people in the room during this session, and to see a standing ovation among them was amazing. But I think it's because in lung cancer, we've had so many advances over the last several years. Things have gotten so much better. There's still a lot of challenges and things we need to do better on for sure, but we've done much better. Pancreatic cancer has not had very many advances. So this was so huge for those patients. So as you mentioned, this was a study that looked at patients with pancreatic cancer, metastatic pancreatic cancer, and this drug was a targeted therapy against RAS, and it was better than chemotherapy. People lived almost twice as long because of it. So on average, so that's amazing. What exciting results for a disease that has seen really minimal advances in the last several years, really ever. So it's really exciting. So KRAS is really common in pancreatic cancer, but it's also actually fairly common in lung cancer. So about a third of lung adenocarcinomas have KRAS mutations. And so this drug is being studied in lung cancer. We don't have this data yet that they have in pancreatic cancer about how it compares to chemotherapy, but the studies are ongoing. We have a trial again at Yale with this drug, again, because we were so excited about the early data that we wanted to have it for our patients. And so it's being looked at in lung cancer. It's so exciting in pancreatic cancer, and hopefully we'll see a really big impact. We do have other KRAS inhibitors already in the clinic, but only for KRAS G12C, which is one of the types. This is a pan-RAS inhibitor. So it inhibits all the types, potentially. I think that's something we still need to figure out. Does it really inhibit all the types or just potentially? So that's something that they didn't provide data on, and we're going to have to see that for ourselves in lung cancer too. But very, very exciting advance for this disease, and then hopefully for other diseases like lung cancer too in the future.
I absolutely agree. Very, very exciting. Amazing to see that in a room, thousands of people from all over standing up and giving a standing ovation. Reminds us, why we do what we do, and this is exactly what we hope for. And so, absolutely, I think it's very exciting, especially in pancreatic cancer. But again, we have trials ongoing in other tumor types. And as Dr. Goldberg mentioned, KRAS is common in lung cancer, not just the G12C, the specific mutation that we have some approved treatments for already, but other types of KRAS mutations. And we have a lot of clinical trials with various compounds to try to target these other KRAS mutations. But I think this is an important option for patients. I really am excited to see the lung data specifically.
Yes, I think you both hit the nail on the head with this. And just one more thing to kind of explain. I think, Sarah was talking about the 2 drugs that we do have approved in the KRAS space for patients with lung cancer that have a KRAS G12C mutation, and that's sotorasib and adagrasib. And those are both RAS off inhibitors. So they basically turn this RAS pathway, which is an entire oncogenic pathway that if it gets signaled or oversignaled can lead to cancer growth, metastasis, all bad things. So you never want that pathway to get overstimulated. So what those sotorasib and adagrasib does, in my mind, I envision it as it just like locking in and turning that pathway off. Daraxonrasib is an on inhibitor, so it actually works a little bit below it to make sure that, it's sort of like if the first pathway does not work, then the second pathway, it's like another way to prevent a bypass mechanism. So it's kind of hard to explain the lock and key mechanism, and maybe one of you can do it a little bit better than me, but I sort of envision it as if the first mechanism does not work, you would automatically want to make sure that you catch something downstream. So I think that's what the excitement is about the daraxonrasib also, is that maybe if someone had progression on a frontline G12C inhibitor, that maybe this might be efficacious. Or if you have a non-G12C mutation like alphabet soup KRAS alteration, that this might be an appropriate option for you. So if you have a KRAS alteration and you're on this call, you should definitely be asking your doctors if there's any protocols for you that you would be eligible for, if there's daraxonrasib, and if there's anything, any combination therapies that would be appropriate for you, because this is really a space that's sort of exciting and really exploding, and I wouldn't want you to be missing any opportunities.
I'll just say one more thing on that note. So because it's a pan-RAS inhibitor, it's not even just KRAS. It's also they're looking at other types of RASs, NRAS, HRAS. So I mean, those are much more rare, but they're out there in lung cancer too. So potentially, again, we haven't seen this data, but potentially those tumors could also shrink from this. We don't know, but they're being looked at.
Yes, so stay tuned, but that's what this drug is all about on a high level. So we're going to move away from the plenary, but still talk about topics in the thoracic space that were presented at ASCO that were really exciting to me. And, data that I've shared with my patients already in clinic and already have made treatment changes based off of some of this data. So first, we're going to dive right into the ALK space. So these are patients that harbor ALK fusions. And we're going to talk about the CROWN data, and then we're going to talk about ALCOVE-1. So the CROWN data, this was a study that has been ongoing for years, looking at frontline lorlatinib, which is a ALK tyrosine kinase inhibitor. And I think we saw the 7-year update on overall survival, which was really exciting to me. Anytime we see more years added and more survival, it's always just like a check in the great column for me. Has this changed your practice at all? Are you now feeling more comfortable using Lorla in the frontline setting? Or did this just reaffirm? Would love to hear both of your thoughts on this.
I can go first on this one.
Yeah.
Absolutely. So the CROWN data, this was an update, 7-year update to the clinical trial. So again, kind of confirmation of what we've seen in the past, which is always good to have that. You always want to see the continued separation of those curves, meaning that the patients who received this medicine, the lorlatinib, did very well. So for me, it was not necessarily practice changing because I already tried to use lorlatinib in the first line setting where I can. But again, reaffirming that decision. I always talk with my patients about their options if they have an ALK mutation. I talk about clinical trial options, which we'll get into next, but I also talk about the standard therapies and what those side effect profiles may be. So it may be that a situation like that is guiding my treatment as well. If some of the side effects of one of the oral medicines is a little bit different than the others and what the patient already has going on, for example, the lorlatinib, especially at the standard dose, can be a little bit difficult to tolerate for some patients, and we may have to go down on that dose. And when I say that, there are some side effects, things like high cholesterol, kind of some cardiovascular type side effects, and also some neurological side effects, some confusion and things in that regard. And so we do sometimes have to go down on the dose, but importantly, we see that if you do go down on the dose for any sort of side effects, that the medicine still works really, really well. So for me, it's a very mindful discussion up front with the patient about what medicine we choose for their ALK-driven non-small cell lung cancer. But for me, when possible, I'm already using lorlatinib. So I didn't necessarily change my pattern, but I tell my patients too, I show them, I pull up, this study is really, really amazing. It's unprecedented, in terms of what we call progression-free survival, meaning that the cancer is being treated well and it's not growing on this medicine. I show them those curves because they're so impressive. And I always say, you can drive a semi truck through these curves. This looks really, really good. And so, like I said, just kind of reaffirming that.
Yeah, I think we always need to think about toxicity and dose reductions, right? We want to make sure that these treatments are palatable and tolerable. And what we say is tolerable is we honestly have no idea. Knock on wood that we don't find out. But if we, I think it's very hard for us to say what's tolerable, and we really have to just go off of the patients. And I mean, are you typically starting full dose Lorla for both your patients? Are you starting low and titrating up? What's your practice? Everyone has a different shtick.
I'll tell you, I've had conversations like about this with other thoracic oncologists, and you're right. People are doing this very differently. So a lot of patients do require a dose reduction for the side effects. And Logan, I forget if you actually said this, but I'll just say this and hopefully not repeating. But one of the things that they showed in this presentation and have shown before is that with the dose reduction, the outcomes don't change. So in some ways, you could take that to mean, well, maybe you could just start at a lower dose. Why even bother? But I don't totally think that's true. It doesn't really say that. It doesn't say that starting at a lower dose is okay. It just says if someone needs a dose reduction, then that's okay. The outcomes are similar. So in someone who I am very worried about side effects, like someone who's older or very frail, or if I had a side effect, it would be catastrophic, I'll start at a lower dose for sure. And someone who I talk to about the side effects, and I think if they had a side effect, they could live through it and talk about it. I talk about, would you be okay if these things happen? I'll start at the full dose, but have a very low threshold to lower it. So if there's any concerns, the cognitive side effects that are often so challenging for people, also weight gain is sometimes really an issue. So then I just say, we know it's okay to lower if you have side effects, and I lower it. So I go both. I do it differently, but I know some oncologists always start at full dose, some always start low. So it's variable.
I've noticed the exact same thing, and I also myself do both. And I agree. I think if I were really worried about side effects in someone, or if they are an older adult, or maybe not quite as a little bit more frail, kind of going into their treatment, I may start at a lower dose and then see how it goes and get blood work and things. Or if they already have some cardiovascular risk factors, things like that, where I think weight gain and high cholesterol and high blood pressure, could have an impact. I will start lower. But I think it's important to note that, this drug was first developed to be given after our other standard ALK inhibitors. And so to overcome resistance of the cancer outsmarting those prior ALK inhibitors, and then doing, better above and beyond that and trying to overcome that resistance. And so you may not need that dose. And I do tell my patients too, we approve the highest dose, but may not be the right dose for everyone. We can't go higher than the highest, but we can go lower. So it may not be that the highest was right for you and your body and your kidneys and your system. But certainly in some patients who I know that they will tell me about side effects, we check in very frequently. I think that they would be able to tolerate them fairly well. We have that conversation. I may start at 100 milligrams, but quick to lower that if they're having some side effects, and reassuring them too. I think sometimes patients think, well, I'm not getting the best treatment if I'm not getting the maximum dose. And I always try to reassure them that that's absolutely not the case here. Or they'll try to tough it out, and I'm like, this is hopefully a drug that you're going to be on for years and years and years. I don't want you to have even a low level of these things if we can help it. And so I do think it's important to note that the efficacy is still there.
Yes, thank you. There's actually a very relevant question in the chat, so I'm just going to raise that to both of you. If someone is doing great on 75 of Lorla, would you ever titrate up to 100? If so, why, if 75 is working?
Clearly, we need some more studies on this because we don't really know, right? The only thing that we know is from what I know. Maybe you all have some data that I don't know about. From the Crown data, where everybody started at 100 milligrams. That was what the trial required. That many patients required dose reductions, and that the outcomes in the patients who required dose reductions and those who stayed at full dose were similar. So we don't really know about what happens when you start at a lower dose, or if you start at a lower dose and you go up, is that better or not? So there's a lot, I tell my patients this all the time. There's a lot we know about optimal treatments for cancer, and there's a lot we don't know. There's a lot of gray. So if someone is on 75 because 100 milligrams was too tough, too toxic, I would keep them at 75. I don't see a reason to try again. If someone started at 75 and is doing fantastically well and wants to try 100, I think that's fine to try if side effects wouldn't be a major issue for them. Although I have to say, if I ever start at 75, there's a reason for that, and I don't usually then go up. But depending on why someone started at a lower dose, it could at least be discussed as a possibility of going up. But it's a completely, as far as I know, unknown answer. Is it better to stay at 75 or go up?
I agree with that. I would do the absolute same thing. If I'm starting at 75, there's probably some sort of reason or some sort of discussion there. If you're doing well, scans are looking good, you're feeling well, there may not be a reason to go up. But certainly if a patient was feeling strongly about trying it, we could always try, with the understanding that we can go right back down and still have efficacious results.
I agree. And I almost would not favor going up unless I had a real clinical reason to. Like, let's say, God forbid, there was progression on a scan or solitary CNS progression, like brain mets that were growing or new brain mets. There is, good data for a CNS penetration or brain metastases penetration through the blood-brain barrier with lorlatinib. So I think that might be a real indication if someone's on 75 to say, hey, let's try 100 and get a short interval scan and see if we can get some more mileage. But I would favor if it ain't broke, don't fix it, let it be. I just that's just my take, but I think each case and each patient and each, environment is totally different. But really good question. Long story short, we don't know the right answer for you, Cindy. But I hope this discussion sort of solidified maybe discussions you had with your medical team. So there's been, oh, sure, there's been a little bit of buzz also in the chat about, well, what else is there outside of Lorla? And maybe we have alectinib, we have brigatinib, we have crizotinib, we have ceritinib, we have all of the other IBs. But there's a newer kid on the block that's in the clinical trial phase right now, neladalkib, made by Nuvalent. This is a newer ALK inhibitor. It's thought to have, great CNS efficacy, maybe better tolerated. I think there's trials looking at neladalkib in the frontline setting and trials looking at neladalkib in the second line and beyond. So I'd love to hear about your thoughts about ALCOVE and maybe if you have any experience with neladalkib studies at your institutions and what you've seen.
I can tell you my thoughts on the trial. I haven't used this drug yet, so I can't tell you my firsthand experience. Logan, do you? If you do, feel free to take it.
Yes.
Okay,
Yes.
you go then. You tell.
So yeah, I'll give my 2 cents worth. So yeah, absolutely. So we have at Ohio State, we have the ALCOVE-1 study. So we have the second line and beyond, meaning you've had a prior ALK inhibitor of some sort, and then you try the neladalkib. And then we also have the ALCAZAR study, which is the frontline study, basically meaning that you have not received a treatment yet, an ALK inhibitor yet, for metastatic non-small cell lung cancer, and it's going up against alectinib. So that was a question in the clinical trial design that we can certainly get into, but they're comparing it to alectinib, not lorlatinib or others. So they're comparing it to that in the frontline setting. And neladalkib is what we call next generation. So the thought is that it's more selective for the ALK inhibitor and doesn't have as many side effects because it doesn't, target things that it's not supposed to target as much. And so the goal is that it more selectively inhibits ALK, and with that also has good penetration into the brain, the CNS, and so it can treat brain metastases, and can be effective after other medicines in the ALK space have been tried. So my experience thus far, I've been the site PI here at Ohio State, and then we also have the expanded access protocol. So we have a ton of patients coming from the region who've heard about the medicine. They're excited. They want to get it before it's FDA approved. And I've actually had pretty good results. It's been well tolerated for the most part. I have not seen the same side effects that I've seen with lorlatinib, and we have had good efficacy. So for me, I'm extremely excited about this. I think it just opens up more options for patients in a space that is needed, and anxious to see, the results of the full study. But at least in our anecdotal experience, it's been good.
Yes, I echo that. We also have this study. We have it frontline and second line. One thing that just comes to mind to me is that we are always looking for reasons why patients with RET fusions have cancer progression, right? So if there ends up being cancer progression because of some known bypass mechanism, I don't know how effective neladalkib is in that setting, right? If there's MET overexpression, BRAF alteration that you develop, I think those, to my experience, and after speaking with Dr. Alex Drillin, who's the PI on these studies at MSK, he seems to feel that maybe neladalkib may not have great efficacy if there's already a known bypass mechanism in which case those patients may want to get local therapy to that oligometastatic progressive site or consider adding chemo. So I'm not sure if both of you have noticed that as well, but I had a patient that was on an neladalkib study that progressed, and it ended up being because there was a local site that was harboring MET amp, and it just wasn't budging. But that might have been unique
Well,
to.
go ahead.
I was just say I think that brings up an excellent point, which is whenever you can, you should be retesting at progression. So when you're on a medicine that inhibits ALK, anytime that you have cancer that has grown despite that, either getting a biopsy if it's feasible, or certainly at least getting a blood test to see did that develop any sort of resistance. And another excellent point you brought up was oligometastatic disease, meaning that if there's only a couple spots that are growing, but everything else is quite stable, it may just be that a clone took off in one area or two areas, and you may be able to undergo some local radiation and continue your current treatment. So I think those are really important things to consider. And unfortunately, these clinical trials, understandably so, they want to know how well neladalkib's working, but they don't allow you to do multiple rounds of radiation or give chemo and continue neladalkib. So some of the things that we do with lorlatinib or alectinib standardly right now to try to prevent some of these clones from growing, we're not able to do on the trial. So a little bit to be determined, but I agree. I think if there's a bypass mechanism, it may not be as effective and may want to try to target it in some other way.
Yes. Just a little bit of buzz in the chat about neladalkib. Let me just see. Some hepatotoxicity. Are you noticing that on your patients that are on study at all?
We get at the per protocol, weekly liver numbers, weekly labs at the beginning of this study. I see it in some. I get the reports, of course, from other places, and we've seen that as one of the most common side effects. But in my own patients, it hasn't been a toxicity or a side effect that has limited our use. There's very clear protocol if you go down on the dose or if you hold the dose for a certain period of time. So it has not. The liver numbers being elevated has not caused me to have to stop the medicine. But again, that's just in my patients who have been on this study.
I'll
Okay.
just add, since I haven't treated anybody in the study, but I have, I did see the ASCO presentation. One of the things I always look at with that type of question, how bad are the side effects and does lowering the dose help, is I look at the frequency of how often you have to lower the dose and how often someone has to stop because of side effects. And it's actually fairly low. Like, some people had to lower the dose because of side effects, but not very many people had to stop it. So, liver numbers going up, obviously, you don't want to damage the liver, but we see that actually with a lot of different drugs. So as long as lowering the dose is effective and people can stay on it, that's usually okay. So that's how I interpret the data, not having firsthand experience with the medicine, but it seems like it's tolerable, especially after you lower it, that very few people need to stop.
Yes, I agree. And I think most of the patients that I have on study have done very, very well. Haven't really noticed much toxicity that we can report, which is really, I'm excited about this drug. So stay tuned. So we're going to move on to away from the ALK space to the EGFR space, specifically patients that harbor EGFR exon 20 insertions. So last year there was all this buzz about sunvosertinib and maybe it getting approved in the States, and I'm still holding my breath. I'm sure you both are too. But there was some more data presented on sunvosertinib and combining with chemo, and maybe this is where it's going to live and this will lead to approval. I'm not sure. Just curious about what your thoughts were about this phase 3 study with sunvo compared to chemo.
I could take this one. So, yes, so this is EGFR. There's a lot of different types of EGFR mutations. When we talk about EGFR mutations in lung cancer, we often talk about common, and then we talk about all the others. So they're called common because they're common. Most EGFR trials are in common mutations. But luckily, there's been several drugs, several trials now for the more uncommon EGFR mutations. And so exon 20 insertions are one of those more rare mutations that we find. The standard drugs typically don't work, although I think we're going to talk about, about maybe an exception to that. But sunvosertinib is an EGFR inhibitor that does seem to be effective for this less common subset, the EGFR exon 20 insertions. Basically, this is probably a smart audience who knows all this, but I'll just say there's different parts of the EGFR gene. And sorry, I got distracted by the chat talking about Aldalkib. So there's different parts of the EGFR gene, and there's different exons, which is different pieces of it. And so exon 20 is just one of them. And it happens to be that most of the mutations in exon 20, the standard drugs don't work very well, but sunvosertinib does seem to be effective. We've seen that for a while. I think it actually is approved now, but you can't get it, right? It's like not they're not manufacturing it and distributing it in the US, which I cannot understand. Maybe someone can help me understand that. But so it was effective enough to be approved by the FDA. It's just not available. I don't understand it. But this trial basically compared it to chemotherapy for patients who hadn't had prior treatment, who had metastatic disease, and it looked to be more effective. So I think this is a win because we haven't had enough success for exon 20 insertion EGFR mutations in the past. So this is great. It was clearly a positive trial. To me, it's not as, overwhelmingly exciting as a lot of the other targeted therapies out there. I don't want you all to think we just get excited about everything that we see, because so far we've talked about like super awesome studies and drugs. This drug looks active. I think it absolutely can be effective, but to me, compared to chemotherapy, it was clearly better, but I feel like we could still do better. Now, does that mean it's combining it like we've learned from other EGFR inhibitors? Maybe the single drug is not enough, or maybe there's other EGFR inhibitors that maybe are more effective. I don't know, but this is a win. Hopefully, we'll be able to use this drug at some point, or get it for patients here. But I think there's still more to go, like more we need to do for the exon 20 so that we can have even better outcomes.
I definitely agree with everything that Sarah said. Certainly, exon 20 has been one of these a little bit more rare and a little bit more difficult to treat in that sense because we just don't have as many medicines that are effective against it. So with sunvosertinib, I too have a healthy dose of skepticism with studies and things, but we just so happen to be talking about, kind of the best of the best of this year's presentations. And so I do also think that it is promising. I do think that it has a role, especially in EGFR exon 20 mutated non-small cell lung cancer. I'm also frustrated that I can't get it. I tried to get it even last week for a patient. What I'm told is that it's approved, it's FDA approved, it's in the NCCN guidelines, our national treatment guidelines. It's just a manufacturing issue. So I don't know what those logistics are, but we cannot physically get it outside of a clinical trial for our patients yet. But with that being said, I think it is important to note that it was in this study up against just chemotherapy alone. And so right now, we know, especially for these patients, that's not really what we're doing in practice. We're not going to get into these studies, I don't think, too much, but there is this medicine called amivantamab that we're using with chemotherapy for these folks up front now, and it obviously did not compare it to that. So it's not necessarily comparing it to our standard. And so it is very promising. It was more effective than chemo alone, but we do have other options and other combinations for folks. But I definitely am excited to actually get this medicine for patients once we can actually obtain it. And I do think these results are promising.
Yes, definitely. And I think, moving out of the exon 20 space, which, you were touching upon different EGFR alterations, right? We have the classical ones, exon 19 and exon 21. We have exon 20 insertion, which is what we were just talking about, which behaves totally different than exon 19 and exon 21 L858R. And now we are going to talk about the atypical EGFR alterations, which is like exon 18 and some of the other ones that we'll dive into, and how actually a drug that Logan so nicely introduced, amivantamab, and another tyrosine kinase inhibitor, lazertinib, actually is finally getting some attention and maybe some efficacy in these atypical EGFR alterations that we had no idea how to do. We were just throwing afatinib at these patients and hoping something would stick and trying anything we can to help them. And maybe there's a signal here. So what were your thoughts about amilaz in these patients? Logan, you want to go first?
Yeah,
Go ahead.
sure. Let's go first since I
You
name
teed
dropped
me up.
amivantamab.
Yes.
Yeah. So yes, I absolutely agree. I think with these atypical, we call them, or just less common EGFR mutations, we have struggled to find really effective treatments. We have things like osimertinib for the more classical exon 19, exon 21 mutations, but we've really struggled. And we've tried to give afatinib, and we've tried to give other medicines, and they just haven't quite shown the results that we hope for. And so I am hopeful in this setting for the combination of amivantamab and lazertinib. I myself have not admittedly used this combination yet. I just haven't had one of these so-called atypical mutations in my clinic thus far. But I would absolutely use it. I think it shows promise as compared to our prior treatments. My concern, I keep going back to this. I feel like with every medicine, is going to be side effect profile. I do worry about some of the toxicities. So I think we have to be very mindful and educate patients if we're going to start something like this. There's a higher risk of blood clots, and so they recommend starting a blood thinner. And there's a higher risk of a lot of skin and mucosal side effects. And so we're lucky here to have dermatologists who specialize in taking care of patients who are on active cancer treatments, but not every institution is going to have something like that. We're also fortunate that we've used these medicines a lot in clinical trials before they're commercially available and approved. And so we have a lot of education materials. Our nursing staff, and other people are very educated on this. And so we're able to have visits with patients and give them a lot of help and support. But I find that if I'm going to start this combination, I'm having almost an entire another clinic visit worth of time that I'm talking about side effects and how to prevent them and what to do. So we're talking about why we're starting it, what the data is, how efficacious it's going to be, but then we're also talking about managing those side effects. And so very excited for the results, but also wanting to make sure that patients are living well while on this and that we're being aggressive about managing these side effects up front.
I will just add, I agree with all of that. I think this is exciting. I think this is another one of the EGFR subsets, these atypical mutations that we really haven't had great options for. And actually, we haven't had that many studies for them because they're always excluded. They don't get included in a lot of trials. The reason afatinib is approved is because they allowed them. It's not that the other drugs don't necessarily work, it's that they weren't included in the big trials, which is a bit crazy. But so the thing that I really still have a big question about, and maybe you all know this, I haven't seen this data, is so this trial was for atypical, or this part of this trial was for atypical mutations, but that still was a few different mutations together. So are they all the same? No, they're not. And so the overall results of this trial looked promising. And I agree, I would consider this as an option for patients, even though it's not approved for this subset. It would be an off-label use, which is okay. But I don't know the results for each individual mutation. And so I'm not, when you see someone, they don't have an atypical mutation, they have one of these, or sometimes actually two of them. But that may make a difference. It may be that for some of these, osimertinib is better. For some of these, I almost said afatinib, amivantamab and lazertinib is better. So I think we just still need to see more data on the different subsets and how those patients are doing so that we can make smart decisions. I don't know that we'll ever have randomized data to really know the answer. So we might have to extrapolate based on various studies, but I think that will be helpful because lumping mutations together just because they're rare doesn't really make that much sense to me. They're different. And so I think you really have to look at them as individual mutations and how they do with the drugs, not just that they're rare.
I think that's a good point. And, I think all the more reason to further make sure that you dissect your next generation sequencing results with your doctor and really understand what is on there. Because to be honest with you, I don't know how to interpret them by myself either most of the time. They're complicated, and I'm always running down the hall and being like, hey, hey, Dr. Chav, hey, Dr. Drillin, hey, Dr. Chris, what do you think of this? What does this mean? Like, can you break this down for me? Like, I always want to make sure that I understand so I can explain to the patient. So if you don't understand, then there's already a gap. So make sure that you understand your next generation results so that you can advocate for yourself. That's takeaway message number one from today. So we are going to actually now move a little bit away from the targeted therapy space to talk about antibody drug conjugates, which are a totally different type of drug. It's almost like someone at a meeting one time referred to it as chemotherapy on a stick, which I thought was really funny. or chemotherapy hiding inside of a Trojan horse. It's like this, the very friendly antibody goes to the tumor cell and binds and then releases this warhead into the tumor, and the tumor sort of, the tumor cell dies. So it's a different mechanism of action of delivering the chemo directly inside of the tumor cell. So there was a lot of data. There's over 300 plus 400 antibody drug conjugates in development. There was a little bit of data on the OptiTrope Lung 05 study looking at adding sacituzumab to pembrolizumab for patients that have PD-L1 positive disease. What were any thoughts about this study? Did it ring true to you? Were you excited about it? Did you go to the presentation? Talk to me a little bit about it.
I'll tell you my thoughts on it. Um, so I think just like you said, there are so many antibody drug conjugates in development. There's also so many trials because for everyone in development, or at least some of them, there's multiple trials in different combinations and on its own and initial treatment, later treatment. So it is an exploding area right now of antibody drug conjugates for lung cancer and other cancers too. It's not just lung cancer specific. For this study in particular, I think this trial was exciting. I think we've started to see some data like this looking at antibody drug conjugates in the first line setting. And so this is combining it with immune therapy, which is one of our standard drugs that we use. So far, I think entirely so far during this session, we've only talked about mutation positive tumors. We're sort of moving away from that now, just to like highlight that distinction. This is for people who have advanced or metastatic lung cancer, but not a driver mutation that we're going to try to target. So this is for most of lung cancer, actually. And so it's exciting in that way, right? We have these great targeted therapies for a lot of patients, but not all patients can get a targeted therapy. Actually, most people with lung cancer can't. So this is exciting in that way, trying to do better than what we already can do. We know immune therapy can be really impactful, really amazing for some people, but not for everyone. And so this is trying to do better than that. We already also know that for a lot of people, we can combine with chemotherapy, and it's better than chemo alone. What this is trying to do is replace regular chemotherapy with this antibody drug conjugate. So I like this concept. It's an intriguing study. It looks like the combination of this antibody drug conjugate combined with pembrolizumab is better than pembrolizumab alone. There's some challenges to like knowing what to do with this result. First of all, I think this was entirely done in Asia as well. I don't think this was a US study, but you can correct me if I'm wrong. So
Right.
that's always a question, like, is this applicable? It also, we only have data on progression-free survival right now, which really our gold standard in this setting is looking to see overall survival, how long people are living. There's a trend towards improvement in overall survival here, but we don't have final data on that. And then I think maybe my biggest concern here is the comparator arm in this trial is immune therapy alone, pembrolizumab alone, which for the most part, we're not using that for people unless they have really high levels of this PD-L1 expression. Sometimes we do, but for the most part, we don't. So the comparator is sort of like not exactly what we normally do. We talked about that with that one EGFR study, same thing. How do you interpret the data if the comparison that you're trying to compare it to is not really what you do? So I'm excited about this concept in general, combining antibody drug conjugates with immune therapy. We have trials like this open here. I'm sure I'm sure you all do too. They're everywhere. We're looking at ADCs as initial therapy for people who've had prior immune therapy, all sorts of combinations. But this data, I'm not sure what we're going to do with this.
I will echo
That was
that.
awkward.
I agree. I think there's so many of these exciting antibody drug conjugates. I'm very excited about the prospect of this. There's so many studies going on. There's so many abstracts presented at ASCO. I think this is promising. But to Sarah's point, I think, our gold standard is really going to see overall survival. Is this actually helping patients live longer? It looks promising, but again, until we find that data, not going to be necessarily practice changing for me just yet, but an exciting concept. And I'll go back to what I keep saying, which is side effects and just making sure that, any overlapping toxicities we think about with these antibody drug conjugates, some of them can have something called pneumonitis or inflammation of the lung, and Keytruda and immune therapies can as well, and ILD, interstitial lung disease. So I'm very mindful with my patients if they already have some underlying interstitial lung problems, just counseling them in that regard as well. So again, looking for efficacy, overall survival, and then making sure that, the juice is worth the squeeze, so to speak, in terms of the side effect profiles.
Thank you both. I think, it's great to have options and great to have, different mechanisms of action, but I think figuring out how they all work together and is it more effective is really the question that's still at hand. So we are going to move on to talking about folks that have early stage lung cancer and how to improve those outcomes next, in the neoadjuvant setting, which means offering them treatment before they go to surgery. And then shortly after that, I am going to hop off. I have unfortunately a conflict, and I'm going to leave it up to Dr. Roof and Dr. Goldberg to take it from here to answer questions and, help have a little bit more of a discussion, in the interest of time that's remaining. So let's talk a little bit about the neoadjuvant space. So there's a lot of approvals with, chemo IO before patients go to surgery, and then sandwich approach or perioperative therapy, which is chemo IO before surgery and then a little bit of immunotherapy after. This space is like booming, but there was actually a study called Alchemist that ended up being a negative study that got presented by one of my colleagues, Dr. Jamie Chaft. And even though it's a negative study, I think it's really important to talk about negative studies because they also teach us, and sort of inform some decisions. So were you shocked by these results? Could you talk to us a little bit about it? Either one, you want to start, Sarah?
Sure.
Okay.
Yeah, so this is like the never-ending trial. We had this trial open years ago. I think it just highlights some of the challenges with doing clinical trials. Like things change over time, right? Like, so you do a trial that was like a very good trial when you started it, and it takes a while to get it up and running. And Jamie did such a great presentation, like talking about that. It was amazing. But then it takes a while to like enroll the trial, have enough people on it, and then get the data. And then so all these years go by, and in the meantime, other trials are going on and things change. And so this trial was done when we did not have neoadjuvant therapy. So immune therapy in this case, before people go to surgery. And so everybody on this trial had surgery first, and then either they got immune therapy, nivolumab, or not. The world has changed. We now, for the most part, in a lot of our patients, most of our patients with resectable early stage lung cancer, they get chemo and immune therapy first, and then they get surgery. So it really is like almost not so applicable anymore. There are still some patients, of course, who get upfront surgery, and then there's a question of immune therapy or not. But we already have a few other trials showing us that data. And so this was a negative study. People did not live longer because they got nivolumab. Overall, there probably are some people who did benefit, but we can't figure out who they are from this study. But I think basically it confirms what we already, well, maybe it doesn't confirm, but I think what we already knew about early stage lung cancer is still true. When possible, people should get chemo and immune therapy before surgery, especially if they have node positive disease, if they, stage 2 and 3. And then afterwards, I think there's still this question, is there benefit to adjuvant? A lot of times we are giving it. There are some cases where we don't, but I think we are still trying to figure out who would benefit from an adjuvant only strategy, only getting it afterwards. In this case, it was not beneficial. This is not going to be a standard.
I agree. I think, negative studies are just as important. We need to have this data. It's very important. We're very thankful for the patients who enrolled in this study and gave their time and energy to this. But it kind of confirms some things that we've already known. And as Sarah alluded to, times change sometimes while you're going through studies and trying to accrue patients to them. And so currently we're using a lot more chemo and immune therapy before people even go to surgery. And then we're using different, as we've talked about earlier, we're using things like osimertinib, alectinib. We're using these other medicines, these other tyrosine kinase inhibitors around the time of surgery as well. So unfortunately, kind of makes some of the data a little bit out of date, and we're still searching for that perfect plan for folks and where adjuvant therapy fits in, meaning after surgery, getting the treatment. But a negative study is still important, and exciting to see what's going on in some of these other perioperative studies that are ongoing.
Thank you for that. I am about to pop off, but I am going to pass the baton to Dr. Goldberg and Dr. Roof, and they will be here to, help answer some questions that may come up in the chat, or if someone wants to come off mute. If there are no questions, there are 2 remaining topics that I guess if either of you have any burning insight about lung cancer screening that struck you, or anything in the small cell space, feel free to share those thoughts. But I think, this has been an amazing discussion so far. I have learned so much. My pad is filled with scribbles. I can't wait to take this back to clinic tomorrow. And I just wanted to say thank you both and thank you to all that joined on the call. And I am leaving you with the best hands ever. So take care, guys. Thank you
Thank
so
you.
much.
We're staying. Don't
Thank
don't
you.
leave
Yes,
this
no,
one.
Dr. Goldberg and Dr. Roof are staying. I'm just jumping off. I had a conflict. Take care, guys. Thanks so much. Bye.
So, Logan, do you want
Yeah.
to talk about one of these two topics remaining, and then we can dive into the chat, lung cancer screening or small cell? You could pick one, and I'll take the other.
Sure, absolutely. I guess I will start with the former, which is the lung cancer screening. Just kind of going in order there. I think lung cancer screening is a topic that's near and dear, I think, to every thoracic oncologist's heart, and obviously patients as well. I'll just start by saying, one of my soapboxes that I'll get on is, why do we have such stringent guidelines for lung cancer screening that we don't have in other types of cancer? So that could be its own discussion in and of itself. I'm happy to chat more. I could talk all day about it, but we have these barriers that are in place. We have very stringent criteria. We have insurance that is giving us trouble. No other type of screening do you have to have this, discussion that they say that you have to have a treatment, discussion prior to having it, like a risk benefit analysis and things like that prior. And other patients can sign themselves up, let's say for a mammogram or a Cologuard colonoscopy. You don't have to have a doctor's order. You don't have to fit a stringent, pack year criteria and things like that. We're also missing patients who may not have had a cigarette smoking history. We're missing folks who are at high risk occupations like firefighters or people who are in the military or other automotive industries, things like that occupationally. We're missing just other people. I mean, we know firsthand in the clinic that we've seen patients who have really no known risk factors and are getting lung cancer. And so just really something that like I said, I could talk about all day. Here in Central Ohio, we have really high levels of radon. And we know that radon is something, it's a tasteless, odorless gas that you wouldn't know that your home or your school or your office has it, and it can cause lung cancer. And so I always advocate for patients to get their homes and their basements tested for radon. You can get that free on EPA.gov. You can get a radon test. I'll get off my soapbox now, but regardless, I think, we don't do enough lung cancer screening. There's so many barriers in place. We know that less than 20% of patients who are eligible with our current criteria are even getting screened. And then we know that our criteria are missing a lot of patients who are at risk for lung cancer. And so I am all for anything that will expand access to lung cancer screening for patients, whether that be liberalizing this pack year criteria, where you may miss folks who are maybe they've only smoked a few cigarettes before a longer period of time, how to even calculate something like pack years, right? That takes mental energy. What does that even mean? And so I think it's just causing a lot of confusion. So I'm absolutely for expanding guidelines. And I think in the future, really important to come up with some sort of screening guidelines for folks who don't have these traditional risk factors. And I see a question here, how do we get around these barriers? I think that is a super important question and one that I don't have all the answers to. But I think, first and foremost, expanding the criteria that we already have, education, education, education to our community folks. I meet all the time with our primary care providers because they're going to be our front line of defense here. You're not just going to jump and meet a thoracic medical oncologist or someone, pulmonologist who's aware of these screening guidelines. Our primary care physicians are overwhelmed with, a million other questions they have to ask a patient during a visit. And so by making this shared decision-making criteria with insurance companies, I think that's just another problem that we face. So I absolutely think that if we, like I said, education, getting the word out there. As I said, anybody I talk to will hear me say, get radon testing done, get your family screened, things like that. But unfortunately, I see here too, absolutely, someone who doesn't have a cigarette smoking history right now, today, through insurance, we cannot get CT scans approved, and there are no guidelines. When do we start? What's the right age? When do we stop? With any screening, we want to make sure that we don't want to increase. There's things called false positives too, right? You're gonna, any screening that you have, you will have some people who might get unnecessary biopsies and things like that. But we've seen overwhelmingly that lung cancer screening saves lives. It decreases mortality. We know that, and so I don't have all the right answers, but certainly we're all here to work with, like I said, the primary care doctors. Ohio State and some other institutions have mobile CT screening vans, so we're actually physically taking low-dose CT screening scans out into the community, some more rural areas who may not even be aware of the lung cancer screening. So we're really trying to capitalize on the current patients who are eligible. When less than 20% of them are getting screened, we're starting there. But, my dream would be to see that this expands to other patients who don't fit these traditional criteria. So absolutely hear you on that. Um, and I see a question here about self-pay. I don't know the full answer for that. I would say a CT scan costs probably a couple $100, but that is like a big barrier to a lot of patients. And also having a physician or a provider who's willing to order that scan. But I think for sure, if that's something that is an option for someone, I think that that's a good avenue to go down talking to your healthcare provider about that. State by state, it's going to be different. But again, I'll stop my soapbox now. I think I'm rambling a bit, but but it sounds like there's some other people in the chat who echo my sentiment here.
Yeah, it's amazing how, it sounds like a lot of people are very passionate about this topic, which I totally get, right? The goal is we always want better treatments, but the goal is to try to catch things early where the treatments are most effective, where we could cure cancer. Um, so yes, screening is so critical. I just wanted to highlight one point, which I think, Logan, I think you said this, but I'll just confirm. Screening is just in someone who doesn't have any symptoms. So right now, CT screening for lung cancer is for people who have a higher risk of lung cancer, which is defined by their smoking history. If anybody has symptoms like a cough, shortness of breath, or whatever, you don't have to have a risk factor. You don't have to be a former smoker or current smoker. So that then you don't even get the low dose screening, you get a regular CAT scan. So that's like a separate issue. So, but the issue is someone who doesn't have symptoms and doesn't have the traditional risk factors. That right now, that's just it hasn't been studied enough to prove that it saves lives, right? The higher the risk, the more lung cancers you're going to catch and the more lives you can save. The lower the risk, even though we all know people who've never smoked can get lung cancer, of course, the risk is lower for sure. And so if it's a lower risk and you're screening people, are you sure we're going to be saving lives? I think we all believe we will, but it's just not proven, which is why the guidelines haven't picked it up and insurance companies don't pay for it. So it's incredibly frustrating because all the time we see people who've never smoked and get lung cancer. So clearly there is a risk. We just haven't gotten there yet to figure it out and to prove it. There's studies ongoing. So hopefully we will get there one day. But for now we're just not there. And so we don't have the ability unless you pay out of pocket, then you can do it.
I agree. Absolutely agree. I think, this opens up a larger conversation about screening in general, and there's always this population level of what's the risk versus benefit. We know in certain high risk populations, and we define high risk with a cigarette smoking history. We know, as you said, to that point, is higher chance that you would have a lung nodule or something that's going to manifest to be lung cancer when you biopsy it. And we're not screening, that population enough because of some of these logistical hurdles. But that's certainly the place to start. And then we need to define other high risk, right? What does that mean if it's not traditional factors like cigarette smoking? Is it where you live? Is it something demographically? Is family history at play? What is it? And we need to really define those things. And just to kind of comment on that, unfortunately, as we've seen that, a lot of times lung cancer doesn't manifest in any sort of symptom until it is advanced. And so we certainly want to try to find these earlier, but how do we define who do we screen? Because if you screen everyone, right, you're going to be getting a lot of false positives or people undergoing unnecessary tests. And then, another point I think to make is that we all kind of see things through a lens of of course, lung cancer is a high risk, but of all the things that a cough or something could be, there's so many other things that it could be that are so much more common. I think that's why these insurance companies have these algorithms where you have to, meet with your PCP and then you have to start a Z-Pack and then you have to get a chest X-ray or whatever it may be, because, far more common is going to be a pneumonia or COPD or something else. But I think we, as a collective society, have to do better to come up with better guidelines. And I think right now, some concerted efforts that we can do is really just to help define the population that's most at risk and to screen the people that we already know are at high risk, because we see that we're already not doing that. So I think that's definitely the first place that we start as well.
Sounds like maybe there should be another whole session on lung cancer screening. Just a note for the LCRF group. I'm definitely not an expert on screening. I think a lot of times it's primary care and pulmonary who are doing the screening, right? Not the medical oncologists, although some medical
Right.
oncologists are that they are very involved in screening. But I totally agree with all this conversation in the chat. Many people don't have symptoms. Even when they do, they're not getting the scans. Huge issues. So there's lots of pieces to this, and it's very complicated, and it's really horribly upsetting and frustrating when you meet someone with lung cancer and they say, "But I had symptoms," or "How did I not know?" So I get it.
Absolutely.
So maybe we'll talk briefly about small cell because we've entirely talked about non-small cell so far, and I can make a few comments there. Um, I think similar to when we were talking about pancreatic cancer, we had very few advances in small cell lung cancer until recently. We've been using immune therapy, PD-1 and PD-L1 inhibitors, for the last couple of years, and they impact how people do, but they're not helping most people. In a smaller percentage of people, they can be really, really impactful, but they're not a home run for most people. And then more recently, we have this drug called tarlatamab, which is a different type of immune therapy. It's kind of an amazing drug, like futuristic, it sounds like. It basically is a drug where it has two parts of it. One part of it finds immune cells, the other part of it finds the cancer cells and then brings them together. So it's amazing to me still that that works, but it does. So tarlatamab has been now approved for the last couple of years, but we're seeing more and more how beneficial it can be. And so I think some of the studies that we saw at ASCO and we've seen in recent months and years is basically showing us the benefit of tarlatamab in patients who've been previously treated with other therapies for small cell lung cancer. And so what we saw recently was that it can work in the brain. I think that's something that we always have a question about. Brain metastases are pretty common in lung cancer, especially small cell. And so I think, that's a space that's always important to look at. And then besides the immune therapies, besides tarlatamab, I think one really exciting advance in small cell that we've seen recently, and there were some presentations at ASCO about this, are the antibody drug conjugates. So we already talked about antibody drug conjugates, that they can be really beneficial for some people with non-small cell. Well, now we're starting to see in small cell as well. So there have been a couple that have been looked at already, many more that are in trials, and we're starting to see some really great results. There's even now some studies that are taking the antibody drug conjugates and trying to put them into the initial therapy. So maybe we don't even need our standard first-line chemotherapies. Maybe we can use antibody drug conjugates instead. It's really exciting times. I think we're starting to see some really impactful advances in small cell. These are only available, the ADCs are only available on trials. I don't think that any of them have been approved yet, but really exciting results. So trials are really great options for a lot of our patients with small cell, and hopefully we'll see some approvals in the future. Olivia, anything you wanted to add about small cell before we maybe turn to the chat? I think it sounds like people have some questions they want answered.
Yeah, I was just looking in there. I was trying to find the questions that we haven't answered yet, because I think at least during the lung cancer screening portion, I was trying to kind of go, and that's why I was a little bit stream of consciousness because I was trying to hit the highlights as I was talking. But absolutely, yes, small cell lung cancer has been a difficult to treat cancer. It's been one that in the past we haven't had a lot of updates in. Non-small cell lung cancer has had these great plenary sessions and these great abstracts, and then it seems like small cell lung cancer and actually a type of cancer that I specialize in, mesothelioma, melanoma have been kind of the stepchildren that don't get as much attention and as much limelight. But I'm really excited that small cell lung cancer, we have a lot of updates. We have a lot of things that are going on. We have new medicines. Certainly, tarlatamab or Imdelltra is a big one. And that has been really a game changer. We're starting to use it earlier and earlier for folks. And there's actually a study that we have at Ohio State. We're trying to use it a window of opportunity before we use chemotherapy. So it's being used in maintenance settings, just kind of all over the spectrum for small cell lung cancer. And we're trying to fight that age-old, standard of platinum chemotherapy and etoposide. And nothing in the past that we've really put head to head against it has done better than that. But we're now finding that we have options next line, and we're trying to challenge the status quo. Another important thing that you may have touched on is that, genomically, we're learning more about small cell lung cancer as well. We know that there are different subtypes. We know firsthand, even in my patient panel, there are some patients who, unfortunately, their small cell lung cancer, despite every single treatment we give it, is just growing, 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 resistant to everything that we have. On the other end of the spectrum, I have some patients who are multiple years, 5+ years out from their small cell treatment, limited stage small cell treatment, whose scans are stable. And so we know that it's behaving differently. We know there's an inflamed and immune phenotype, but we're not able to get that information in real time clinically right now and have that actually change our practice. We know that in the lab, we know that in clinical trials, but we don't yet have like a biomarker driven approach in small cell lung cancer like we do non-small cell lung cancer. But I do think the attention that it's getting is very important. Some of these early advancements that we see are important to build momentum. And I am excited about some of these other antibody drug conjugates and trying to kind of define what population is going to benefit from what treatment and how do we sequence these treatments.
So we're trying to monitor the chat, but there's lots of questions and comments in there. I think I just tried to look through to see if we've missed anything, and I'll just maybe say an overall like summary of maybe a few other topics we could talk about. There were some questions about BRAF, ROS1, and then about other RET inhibitors that we haven't talked about. So maybe we can touch on those. And if we missed another question that people had, GLP-1 inhibitors, you could talk about that too. People, maybe if you don't mind putting additional questions that you might have, or questions you already asked, but we haven't answered into the chat, besides the BRAF, ROS1, and RET, we'll get to those. Logan, you want to take any of those and then I could take the others?
I was trying to think if there were any updates that I had on any of those off the top of my head. Maybe if you start and then I can fill in because I can't think of any right now.
Yeah. So I don't know about us updates at ASCO, but maybe just an overview of we just talk in general. I think BRAF, I don't know that there were updates at ASCO or at least anything that really was so practice changing or different. I think there's been a few great advances for BRAF in recent years. Some of those drugs are challenging to tolerate, so side effects are sometimes an issue for people, and I'm often thinking about lowering the dose or adjusting or switching. Luckily, now we have 2 different regimens for BRAF. I think that is another space where targeted therapies for previously treated, people who already were on targeted therapy, so like the next line of targeted therapies is really important. That needs more investigation, and I don't know of anything that's really close to the clinic that's coming in that space. I think the comment that was asked about BRAF was about immune therapy. A lot of times people who have BRAF mutations in their cancer, immune therapy works very well. So, some of the mutation subsets of lung cancer, like especially EGFR, ALK, ROS, RET, immune therapy really doesn't work well. But with BRAF and others too, like MET, immune therapy can work very well. So we often, of course, try the targeted therapies for BRAF, but immune therapy is another great option that I often will try for patients with BRAF mutant lung cancer. That can be helpful. I don't know about updates at ASCO though.
Yeah, I agree. I wasn't sure if we were focusing on ASCO or not. I didn't see any there. I think in the ROS1 space, I think that was another thing that was asked. I think similar to some of these other driver mutations, it is lesser common one than let's say EGFR or ALK, and so doesn't always get quite as many studies or things. But I do think we're having a similar paradigm, which is how do we sequence the treatments that we already have? How do we get medicines that go into the brain, CNS penetration, and how do we overcome resistance to earlier generation treatments. And so, there is a relatively newer medicine, taletrectinib. I don't know if maybe that was one of the questions too. And so we each, similar to ALK or these other targeted cancers or driver mutated cancers, we have more and more selective treatments, oral treatments, and the goal of each of these is going to be hopefully to more selectively target that mutation, not have as much bystander effect and other side effects that are unintended, to get the medicine actually where it needs to go all throughout the body. We know that brain metastases are more common in these patients, and so we want to prevent those and treat those when they come. And then how do we overcome resistance? And so I do know that the taletrectinib data, it was able to overcome some of those more common ROS1 resistance mechanisms. So that is exciting. But again, the same thing I'll say is kind of sequencing them and managing toxicity. So how do you counsel folks on what side effects to plan for if they're going to be on these medicines, hopefully for years and years? A grade 2 or grade 1 for years can be quite impactful to your quality of life. And unfortunately, we see sometimes the more medicine gets into the brain to treat cancer, the more brain-related or CNS-related side effects it can have too. So wanting to be mindful of that up front. And when do you lower the dose? When do you hold the medicine? How do you sequence those treatments?
I will comment on RET as well. I think, we have our two FDA approved RET inhibitors, pralsetinib and selpercatinib. We already talked about selpercatinib in the long time ago, an hour and a half ago when we started this session, when we were talking about early stage lung cancer. But in the metastatic setting, we have those two drugs that are approved. I think one of the studies maybe that we can discuss is the study that was a study of another RET inhibitor called lenvatinib. I don't have any experience using this drug, Logan. I don't know if you do, but
I do not.
this is what's called a next generation RET inhibitor. So potentially better than what we have now, but I think that still remains to be seen. So the results we saw at ASCO looked really promising. There was a good response rate. I think people were overall doing well, whether they were previously treated or it was their initial treatment. I think the issue is we don't know. So there's not a randomized study versus the RET inhibitors we have now. So is it really better? We don't know. And then there's also no data that I know of, and they didn't show this at ASCO for this drug after the prior RET inhibitor. So when they allowed previously treated patients, I don't think they could have had selpercatinib or pralsetinib. So will it work after prior RET inhibitors? We don't know. So the paradigm we use with like ALK and ROS with trying to sequence different targeted therapies, we don't know if that's going to be beneficial for this drug. But it does look promising and it's moving forward in trials and they're looking at other, combinations with chemotherapy and other things. And so I think it's something to keep an eye on, but I think for now, I think we don't have it available anyway. It's not approved, but it's promising. It could be a drug that we use in the future. But more is needed to really know how that's going to pan out.
I see another question. I don't know if we talked about transformed small cell lung cancer. Did we skip that one? I can touch on that one unless I'm missing another one prior. So is treatment for that type of small cell lung cancer different than small cell lung cancer from the beginning? And I think in a few ways, yes. A lot of times these transformed small cell lung cancers are arising from a driver mutation, as we've talked about, EGFR or ALK mutation or others, and then it becomes resistant to some sort of treatment that we have, and then small cell lung cancer, it transforms into a different phenotype. And so I think definitely important to biopsy. That's another plug that I gave at the beginning. Anytime you have progression of your cancer on one of these oral medicines with the driver mutation, I do try to advocate for a biopsy where possible to see if there's any resistance mutations that we need to overcome, or if the cancer is actually transformed into small cell lung cancer or otherwise. And the treatments, I would say, the way that it's different, and Sarah, you may speak on this. You all maybe have a different protocol or practice, and I think every oncologist I ask is slightly different. Let's say someone was on osimertinib and then their cancer transformed into small cell lung cancer. Some oncologists will continue the osimertinib because there's still data to say that you're still repressing that clone of the cancer, that it still is a driver in a way. And then you're also adding the more traditional small cell lung cancer directed chemotherapy, like the carboplatin, etoposide, things like that to the mix. So I think that is helpful. I will try to get the biopsy in that case, and I'll also repeat next generation sequencing. So I know, does the cancer still retain that original mutation? So I think your targeted therapy would still be helpful in that setting. The other thing that we differ in this way is that we know that immune therapy doesn't work as well for patients who have, let's say, EGFR or ALK, driver mutated non-small cell lung cancer. So we often don't use that in the paradigm with chemotherapy or even as a maintenance treatment. But it brings up a really interesting point with tarlatamab, which we touched on earlier. And we don't have enough data to really know the answer right now as to how effective tarlatamab would be in this setting. We just don't have enough patients to really know. But what I do in my practice is if I have something like this, when I get that biopsy, I will actually send testing, immunohistochemistry staining for DLL3, which is the molecule that tarlatamab targets. So if that cancer expresses that DLL3, I will then, have rationale to give the tarlatamab. But if it doesn't express that, there may not be a target for the tarlatamab to attack. And so hopefully that answered that question. But I think those are some of the key differences when I think about different types of small cell.
You're running very low on time. I think maybe I'll take this last question and then we can probably have to wrap it up. So the question is about if you apply the same paradigm of using adjuvant therapy after surgery for people who get radiation. So this is such an important question because for people who have early stage lung cancer, a lot of them go for surgery, but some people go for radiation instead, whether it's because they have too many, lung issues and they can't get a big surgery or they just don't want surgery. Radiation, SBRT, it's called in this case, can be very effective. I have similar outcomes as surgery. And so the question is, should you then do what you would do after surgery, after radiation? The answer is we don't know. There really have not been studies to look at this that I know. I always say that I know of because there's so many studies out there. Like maybe I missed it. But I don't know of trials, at least with targeted therapies after SBRT. The trials we know about, we talked about before, we know about selpercatinib for RET after surgery, osimertinib for EGFR after surgery, and we also know about alectinib for ALK after surgery. Do those all apply after radiation? I don't know of any studies that tell us they do or don't. So then it's always a question, do you do it or do you not do it when you don't have the data? And this is something you have to just talk to your doctor about because we, in general, will often prescribe things off label because we just don't have the data, or we have some data, but it's not FDA approved that way. But there's pros and cons to that, right? If it hasn't really been studied, we don't really know that it's beneficial and we don't really know the risks. Could there be different side effects after radiation than after surgery? It's possible. So I think it's something that needs to be discussed. I would absolutely consider it and talk to someone about it. The only thing that maybe is a caveat here, besides all of that there's no data on it, is most of the time SBRT is given for a very early lung cancer, usually like a stage 1A. And in that setting, there's really no adjuvant therapy that's even approved after surgery. That's something that's being studied. So probably for most people who get SBRT, they're not really, or even who would have gotten surgery, they're not going to be eligible for an adjuvant therapy anyway. But all good questions to talk to your doctor about and to see if it makes sense. And sorry, one last thing, which is you didn't, it's not targeted therapy, but with immune therapy, there really is not a benefit after SBRT. That has been looked at, and actually there could be some harm. So again, you can't always just extrapolate from the surgery setting to the radiation setting. Logan, anything you want to add, or shall we wrap it up?
I agree with that. I think that I was going to say, thinking about any potential side effects after radiation, like inflammation of the lungs, pneumonitis, immune therapy, TKIs can also cause inflammation, so the timing would be important. But absolutely agree with that. Thanks everyone for your great questions. This has been a really robust discussion. I've really appreciated everyone's great questions. This has been excellent.
I agree. This was such an amazing discussion, and thank you all for being here and being such great participants and asking so many great questions.
Yeah.
Amazing, amazing group. Um, LCRF team, anything you wanted to say in closing, or shall we wrap it up?
No, just thank you both, Dr. Goldberg and Dr. for being here, and of course, Dr. Preeshagul, who had to jump, and everyone who joined us today, and some great, exciting stuff out of ASCO, and we look forward to seeing you all in the next one.
Bye,
Take care, everyone.
Thanks so much.
Bye.